China says the number of people infected by a mysterious respiratory virus has more than tripled over the weekend.
Beginning Sunday, all non-essential workers ordered to stay home.
This is the way it's going to be, not for a few more weeks, but until the summer most likely, and then even after that.
Major events around the world have been postponed or canceled because of fears over the coronavirus.
Welcome to Hint Summit 2D. My name is Zach Holdsworth. I'm the CEO and co-founder of Hint Health. Thanks so much for everyone who's here with us watching this first virtual Hint Summit and really kind of interacting and being part of this awesome event. This is actually the fourth year we're doing this. It's twice as big as last year, and so it's really hard. It's just really sort of humbling that there's been such a great response to this conference. So this is our first year where we're going virtual. And with that, we're going to kick things off. I'm super excited to hand over to Jamie Lagarde, who's the CEO of Sedera. And Jamie's going to be announcing our first speaker.
Hello, everyone, and thank you for the opportunity to join you all today. My name is Jamie Lagarde. I'm the CEO of Sedera, a proud Hint collaborator, and I'm also a 3-time Hint Summit attendee. I'm excited to greet you all today and tee up what I believe will be one of the most compelling presentations you'll hear for the entire summit. But before I make that introduction, I'd like to take a moment to talk to you about Sedera and the mission we're on to make healthcare direct, personal, and affordable. Sedera is a nonprofit medical cost-sharing community that offers an innovative, non-insurance approach for managing large healthcare costs. Like those of you in the direct care movement, we believe that there are compelling healthcare options outside of traditional insurance. And like you, we know that coverage doesn't equal care. Sedera members believe in the power of community. We believe that our medical cost-sharing model unites people toward a common goal of restoring values and accountability to the healthcare system. We've been busy these past few months making big changes, and I hope you'll take advantage of the opportunity to hear later today, to attend our breakout session and hear from Erica Kraus, Sedera's head of brand. Erica will talk about the huge investment we've made to build a cutting-edge fintech platform and technology-driven member experience and what that means for partners like you. These enhancements, along with our new improved Hint experience, will help create a clean and simple integration to further propel the direct care movement. But before I give it all away, back to the introduction. Like Sedera, our next speaker is focused on solutions, and we both embrace price transparency and direct access to care. Our next speaker is a professor of surgery at the Johns Hopkins University School of Medicine. He is a professor of health policy and management at the Johns Hopkins Bloomberg School of Public Health, has served in leadership roles at the World Health Organization, and has published over 250 scientific articles, is a member of the National Academy of Medicine, and is editor-in-chief of MedPage Today, serves as the executive director of Improving Wisely, a national collaborative to reduce unnecessary care, is a graduate of Bucknell, Thomas Jefferson, and Harvard University, and completed his surgical training at Georgetown University and subspecialty training in surgical oncology and gastrointestinal surgery at Johns Hopkins. And finally, our speaker is a New York Times bestselling author. In fact, his book, The Price We Pay, is required reading for anyone joining the Sedera team. We consider it the textbook for the one-on-one class on transparency and cost containment. I highly recommend it to all of you. I'm proud to introduce today Dr. Marty Makary. Marty, good to be with you again.
Jamie, great to see you, and thanks so much for having me. Well, Jamie, first of all, thanks for the great work at Sedera. It's really remarkable to see how you can cut through all the middlemen, and so I'm a big fan of Sedera. Folks, Jamie is really an incredible leader in healthcare. I think one of the big disruptors, and I'd like to call Jamie a friend. I cut his hair, so I hope you like his haircut. We call that a minor procedure, but I think yeah, show it off there. It looks good, doesn't it? That's some good work.
I think you're trying to take credit for my wife's handiwork there, Marty. I don't know.
Sounds like you got a second opinion and switched loyalties there.
Well, I apologize on that, but she's in charge of the family downstairs, so I think I have to give her a nod in that direction. But on cost containment, you sure have her beat.
I won't take credit for Zach's haircut, but I see that it looks really good. Zach, thanks for everything. Thanks for having me. And I know you've got a great lineup of speakers here, so I'm really humbled to be joining you. I want to talk about the broad trends in healthcare today and why I believe that primary care is at a key position we've not really seen in over a century of healthcare. So if we were to look at the system as a whole, if we were to look at how we measure healthcare, okay, let's look at this broader question of how we measure healthcare. Okay, and let me know if you're seeing everything okay here, Travis. Give me a little bit of a green light because there's no feedback sometimes when you're speaking on these. Okay, good. I'm seeing that as a positive. Good. Feel free to throw any compliments in there in that chat box. Folks, that's like an internal chat box. So, if you want a question to start the question period off, you can ask something like, Dr. Makary, has the Nobel Committee heard about your work? And I'm happy to answer questions like that. Now, what is happening in healthcare? Right now, there is this entire complex, okay? This entire gigantic complex of measuring quality using things that don't really matter to patients. They are things that are easy to measure in a registry. When you look at big data, they're inexpensive measures. And this entire measurement industrial complex, while it has driven some good improvement and it does measure some meaningful things, it is extremely expensive. It cost $16.4 billion, according to a recent Health Affairs article. And that's the equivalent of every doctor in America having half of an FTE. Now, tell me what you think we would prefer to have, help or this giant measurement industrial complex. Now, we need both, but we've been measuring things that are the result of doing things. We're measuring the consequences of doing things, not measuring whether or not a patient needed something. Okay, so a patient comes in to see us. Think about this sort of basic graphic. A patient comes in to see us. We do something, and then we ask ourselves, did they get an infection? Did they get readmitted? Did they have a coded complication? But what we're asking is really a consequence rate. It's not comprehensive health outcomes. In fact, what we're capturing is simply the result of doing something. We're not capturing whether or not the patient needed that operation or needed that diagnostic test or that MRI or the lab test or the referral. We're not measuring whether or not they needed that care. We're not measuring the appropriateness of care. Now, how much of quality is the appropriateness of care? I would submit to you it's most of care. Think about what we look for when we look for a doctor for ourselves. We want somebody who has good judgment, who has good skill, who knows their limits. Probably one of the greatest qualities of a physician is their humility, their willingness to ask for help when they need help. Those are the qualities that we all seek when we look for care for ourselves. These are things that are entirely unmeasured. Take, for example, the opioid crisis. Okay, one manifestation of the broader crisis of appropriateness in care. That was just one medication. Okay. Now, asking what percent of people who received an opioid had an adverse reaction is one question, and a question we should ask. But how about whether or not that patient needed that opioid? About 10 years ago, we prescribed 2.4 billion medications. Last year, it hit 5 billion. Did disease really double in the last 5 years? No, we have a crisis of appropriateness. And so this is something that we can measure. And if there's one theme in the medical literature in the last 7 years, it has been the appropriateness of care. Call it precision medicine, call it good science. We are learning through a flurry of articles that are now flooding JAMA, the New England Journal of Medicine, and many specialty journals that indications that we previously thought were broad are in fact far more narrow than we appreciated. Speaking to that issue of appropriateness, of sound judgment, of clinical wisdom, things that don't get through the National Quality Forum or NCQA or make it to the Medicare Compare.gov rating system. Sound clinical judgment. In my own field of surgical care, appendicitis, something that we've treated with appendectomy routinely, has been recognized in 3 large randomized controlled trials, all published in the last 5 years, to be a condition where the first-line therapy should be antibiotics when there's a non-ruptured appendix with no fecal dith. And that's most appendicitis that walks into the hospital. Treating appendicitis with antibiotics, are you kidding me? I mean, this was almost heresy in the field. But the data are clear. The studies were sound. The follow-up is now long-term, and it is clear that the first-line therapy for uncomplicated appendicitis should be antibiotics. Now, I tried this when the studies came out. I began by offering it to a patient. I explained the new studies that had come out and offered the option of no surgery, and between surgery and no surgery, guess what? They chose no surgery. I wasn't offended. This is the modern era of the appropriateness of care. We're recognizing indications are more narrow than we appreciated. Total knee replacement, a randomized controlled trial in the New England Journal of Medicine shows that NSAIDs and physical therapy work as good as total knee replacement for moderate to severe osteoarthritis. This is the trend. Papillary thyroid cancer, diverticulitis, you name it. Go down the list. We are learning about the appropriateness of medical care. Even in standard cholesterol testing, the lipoprotein A test is emerging as a broad screening tool for those at risk of early heart disease. It is one of those lipids, a subtype of LDL, that lodges in the inflamed coronary artery wall. Now, this principle in vascular surgery is coming to the mainstream, and people are saying everybody should be tested at least once in their life to see if they are prone to express a high degree of lipoprotein A. And if you are, maybe those are the subgroup of patients that need more aggressive follow-up. It's amazing. We're learning more and more about what we should be doing and the best form of medicine. You know, we have a broken healthcare system, and it's not a system we designed, it's a system we inherited. And if you look at best practices, if you get docs together and just ask docs, hey, what do you think is the best way to treat somebody who comes in with high blood pressure? They'll, with enough time, they will talk to you about the underlying drivers of high blood pressure. That is the incredible art and craft of the medical profession, different from any other aviation-based set of triggers and algorithms. Sure, there are best practices we need to standardize better, but that is the beauty of physician liberty to customize care to an individual's patient's physiology, physiologic reserves, and their personal goals. Maybe we have too much of a reactionary healthcare system. Maybe we're not talking about these issues that the American College of Lifestyle Medicine is putting out, that many primary care doctors are talking about, that others in the world are talking about. People like Peter Attia with his health podcast, The Drive. doing deep dives into issues like hormone replacement therapy, talking about misunderstanding, misconceptions, misconstrued studies that have made it to the mainstream. You know, we spend, in my own field of surgical oncology and gastrointestinal surgery, we spend a tremendous amount of money trying to come up with drugs. But yet many of these conditions are preventable. Many of these conditions are related to lifestyle. Many of these conditions are connected to what we eat, how we live, environmental exposures, which may be at the root of some of the increased rates of cancer that we observe. Now, we spend $80 billion at the NIH on cancer research each year. If anyone tries to trim that by one penny, they get slaughtered in the policy world. Okay, and you could argue we need more money for cancer research. I believe that personally, but all for drugs? How about studying environmental exposures? I grew up in the coal mine anthracite region of central Pennsylvania. My dad, as a hematologist, saw all kinds of exotic leukemias and lymphomas, things that colleagues at major academic medical centers were baffled by, things he couldn't believe at the prevalence rate of these leukemias. Maybe we can study environmental exposures instead of just drugs. What is our return on investment on $80 billion for drugs? Well, a top meeting at ASCO, the American Society of Clinical Oncology, a few years ago, had the top paper, the use of Avastin for brain cancer, already used for other types of cancer, extending life by a matter of a couple months. That's the return on $80 billion a year. Think about what that $80 billion could do in primary care, addressing the underlying causes of illness. Think about the conversations. Think about the new generation of doctors driven, I believe, by direct primary care doctors that are not bound to the constraints of the hamster wheel on the billing, coding, throughput, insane cycle that is a system, again, we did not design, we inherited, and we accepted it. And sometimes we still see people grinding in that system. Now, look, primary care attracts saints. To do primary care means you're a special person. It means you like spending time with patients and addressing underlying issues. It means that you're a people person. It means that you're interested in a broad spectrum of medicine. And that should be our most noble specialty, not just the specialties that have lobbied the RRC committees to ensure that their procedures get higher reimbursements. The primary care is the golden jewel of the entire healthcare system. And that's where these conversations are happening. People are now starting to ask the big questions. And maybe we should. Maybe it's time we ask, should we be treating back pain differently? Maybe back pain should be treated as often with physical therapy and ice as it is with opioids and surgery. These are the conversations that are healthy and they're refreshing. Maybe we should treat more diabetes with cooking classes. Maybe we should treat more hypertension with talking about quality sleep and stress management. Maybe we should start talking about treating more cancer patients with dignity as much as we talk about treating them with chemotherapy and surgery. Maybe we should start talking about treating the underlying public health endemic behind many conditions, a problem that we need to talk about that we're not talking about, that is one of the greatest public health problems in America today, and that is loneliness, rampant among our seniors and exacerbated during this pandemic. Maybe we should start talking about treating some of these conditions with communities. Maybe we should start talking about treating inflammatory conditions that are systemic with healthy whole foods and low inflammatory behaviors and things that people eat. These are the conversations that are driven not by the coding throughput model in healthcare, but by primary care, forward-thinking doctors, and I believe driven in large part by relationship-based primary care clinics like direct primary care. So as a specialist, I want to say thank you for what you all do. It's pretty remarkable. I observed recently in the Iora clinic, the third chair in the clinic, where patients get a coach assigned to them. And the coach sits there in the clinic and listens and meets with the patient before the physician or nurse practitioner or PA comes in. And that individual talks about what you'd like to go over with the doctor. Afterwards, the health coach stays. Now, the health coach is not a highly trained medical profession. The coaches are hired based on empathy and compassion and willingness to serve. And imagine how much more effective the clinician is with that partner, and how much more effective the patient is in not only participating in the plan goals, but in having that care better coordinated, something of utmost importance with seniors. This was pretty impressive. This coach enables another point of view when they do the morning rounds each day. They spend a lot of time with patients. This is the future. And when we develop measures of appropriateness for specialty care, guess what? It is these primary care clinics, especially when they're globally capitated, that are driven to make sure patients get to the right specialist. I want to just conclude by talking about the problem of healthcare costs. We have a fundamental problem in healthcare that is affecting patients. Medical quality is not just infections and readmissions, it's billing quality, it's financial toxicity. Billing quality is medical quality. And right now, people are getting cured of their illnesses, but getting destroyed financially. The fundamental problem in healthcare is that we have non-competitive markets, and that limits a lot of advancement. When you have non-competitive markets, you can say, we can create rules within these non-competitive markets, but ultimately the way to transform those markets is to enable competition within those markets. I'm not talking about competition at the level of the insurance markets. I'm talking about prices. I'm talking about those who either shop or are proxy shoppers. They want to know what an honest price is for a service. Now, imagine you went to Kayak or Travelocity or one of these websites, and you looked at a flight, but there were no prices. Imagine the prices were gone, and instead you simply see the flight, and the airlines tell you, we have to bill you after the flight, and we don't know what the price will be. Guess what? There would be gouging all over the marketplace. There would be outrage. There would be a loss of trust in the aviation industry. There would be animosity. There would be tremendous public sentiment to reform this system, to create the equivalent of food labels, and then to allow competition to work. Well, this system is implausible, right? If a pilot, had to bill more because they experienced turbulence on the flight and had to work harder and then land the plane and bill more RVUs because the flight was more complicated and they had to work a little harder, we would say that's ridiculous. And if you have to do that, simply price it into a predictable price before so that somebody knows what they're walking into. None of us believe in surprise bills for a Coca-Cola on a flight. And if that bill were $500, we'd say, you know what? The industry is taking advantage of people at a time when they're thirsty on a flight. Yet that's basically what we're seeing in healthcare. We did the original study on what we call the markup, and we try to avoid the charge to cost ratio to put things in terms that are in plain English so everyday folks can understand them. Looking at the markup at hospitals, now markups are not bad if it's proportional to quality and the demand is there, but when people get slapped with the bill after the fact, those markups turn into price gouging, if we can call a spade, and predatory billing practices. The markups can be as high as 18 or 23 times higher than what Medicare will pay for the exact same services. Sometimes the markups are different in different places in the same hospital. The price to deliver a baby in Boston ranges from $7,000 to $31,000. In New York, it ranges from $6,000 to $70,000. Now, I guarantee you, none of those OBs have any idea what those charge master prices are because we don't have transparent competitive markets. Now, when I talk to CEOs and I tell them, you've got the highest prices in the country for the standard cabbage surgery, the arguments that we hear are that, Marty, nobody is expected to pay those bills. So my research team, mostly of young millennials, and I decided to really look deep into this question. Are people expected to pay these inflated, marked up bills. And what we found is that there were a lot of people expected to pay these bills. And when they couldn't pay them, about a third of US hospitals would sue them in court to garnish their paycheck. We did research studies on this showing that in one hospital, there were 24,000 lawsuits, 25,000 lawsuits by one hospital in a town of about 30,000 people. They sued the judge by accident in another town. The most common person sued was a Walmart employee, followed by a food service worker, followed by a postal worker, followed by a hospital worker, a custodian, or a nurse assistant. These are not wealthy individuals getting sued. These are people who live paycheck to paycheck, who have insurance. We documented this in an article in JAMA last summer, and we blew the whistle, called many reporters, told them to write about this. I published it in the book, The Price We Pay, and most of these hospitals have decided to finally stop suing patients. But the financial harm is still there, and the predatory billing does persist. Travis, if you can play a little video, we have a filmmaker on our research team, and he's a medical student. And he told me, Marty, I want to help share these stories. So we had him tell a couple of these patient stories. We've put his short films, they're about a minute or two each, on our advocacy website, restoringmedicine.org, if you're interested in this topic. And I write about it in the book, The Price We Pay.
We're not making any money. I'm a housewife, and he just stopped working recently.
I'll go out and help a buddy do some work just to get a few $100s to help feed the family. And by trade, I'm a carpenter. Well, she didn't want me to worry, so she didn't tell me till last night. I just got the news last night.
Yeah.
I didn't know.
It's like we owed $5,000 some for, I think it was 2 visits. ER visits. $5,000, that's a lot of money, especially people that, don't have any money.
It's hard, it's a struggle, I know that.
They didn't say it was, how much it was gonna be, nothing. They just sent us on out the door with just discharge papers saying what he was,
diagnosed and all. That's right. That's exactly right.
When you go into the ER there's no price of anything. Even when you ask people, they don't tell you anything.
So they could really put any number on there.
They put anything.
And you don't know any prices.
Until weeks later when they send you the bill. It's nothing you can do. It's their rules and it's their policy, and it's kind of like a monopoly. You have no choice. If you're sick, you're that sick, and you have to go to the ER, you have no choice.
I've offered to defend any patient who is sued pro bono, and I will argue their case as their medical expert for free. And we have done this around the country, and we win 100% of the time. It violates everything sacred about the doctor-patient relationship. We've lost control of our billing processes. And with this system, it makes no sense, and it is threatening the great public trust. We got the bipartisan executive order. When Secretary Alex Azar took an interest in this, there was no partisan opposition. This was something that was signed last November and upheld in the court last month. This is the executive order on price transparency to end the secret negotiated discounts between insurance companies and hospitals, and to offer real prices for common shoppable services. When American hospitals were built, they were built with an incredible mission. Read their charters: Pennsylvania Hospital, Johns Hopkins, the University of Pennsylvania, to take care of all of those in need regardless of one's race, creed, or ability to pay. Many were founded by churches. They had an incredible mission to serve their communities. That is our great medical heritage. And so the next time somebody asks you, how do we fix healthcare in America? You can remind them of our great public trust. So with that, I'll say thank you. Thanks for having me. Happy to chat more, and good to be with you guys. Okay, so A couple questions here. How do we best gauge or measure progress in making the changes to our healthcare system's needs? Well, I think, first of all, a bunch of us have tried to recognize that the journals are way too slow and clunky for us to really be advocates for our patients. You can't have policy decisions going on with, 6-month peer review times in the journals. That's why ZDogg has done a tremendous service by being a voice for physicians in real time using his platforms. I think that's a great platform. Peter Attia has done the same. I'm the editor-in-chief of MedPage Today, and if that's a venue that any of you would ever like to write for, just send me an article and we will post it. This is the conversation that we need to have in real time to be advocates for our patients. You're going to hear an announcement later today about surprise billing. Don't let the arguments that there has to be arbitration to settle surprise billing get in the way of some form of surprise billing reform. The proposal that you'll likely be hearing about this afternoon is neutral on whether or not surprise billing is best addressed through arbitrary-based pricing. Okay, let's not let the infighting kill the reform, and let's think about our patients. Hospitals need some accountability. They often say we have no control here. These are private groups that are sending surprise bills. Well, if it's for elective care, they should disclose that it's out of network. Another question, do you see the coronavirus experience as something that ultimately spreads or slows action to solve the problems in our healthcare system? I think it is. I think it is improving the speed of innovation. Coronavirus has been terrible for the world. It has been good for some legacy infrastructure things. Things that we were doing that made no sense are now getting challenged in every industry because of the pandemic. Look at value-based healthcare versus the fee-for-service treadmill, okay? You've got clinics that are globally capitated. You've got direct primary care clinics thriving, taking care of their patients, responding to the need, resourced adequately. And then you have fee-for-service care on this gravy train, okay, of an addiction to the fee-for-service payment model. And the second that dries up, there's a begging of the government to have a taxpayer bailout. That's not a good, resilient system. And so when you look at clinics that have thrived during the pandemic, there are lessons there for the broader system. Look, I'm a fee-for-service doctor. It's not a system I designed. It's a system that I work within. I've inherited. And this is a system that we can challenge. It is not a fate that we have to accept. So I do think we're learning a lot of good things right now about research, crisis response, and our infrastructure. This is not the last crisis. There are other forms of crises. There are hurricanes and earthquakes. There are mass shootings. There are other viruses that will be at pandemic levels. So we should take some lessons away from this experience and create a more resilient, expandable healthcare system, and one that allows us to do research rapidly.